All right, this is Emily Peters, recording about Chapter 5 of Care of the Growing Family, Newborn Adaptation. This first several slides, I may talk through them frequently and jump ahead if I've already explained something that's on another slide, just so you are aware. All right, so let's get started. So, as we all learned already in this semester, pregnancy is a time in a woman's life where she's going through lots of changes with her body. Well, also the same things are going on with the baby. The baby's going through lots of changes during pregnancy, but those changes are not ending until after the baby is born. In fact, that baby is still going through multiple changes to get ready to be on its own even after it is delivered. So over the next few hours to days, we might see some changes in the newborn. So what causes some of these changes? Well, some of the first changes are in that respiratory system. And that baby needs to learn how to breathe on its own. Chemical factors, thermal factors, tactile factors, sensory factors, all of those things are going on. In utero, the baby is in an environment that is warm, quiet, and kind of dark in a way. And then when it is brought out into this world, it is in a cold, loud, bright environment. And while that process is happening, a lot of things are changes. The kid's seeing things, the light, it's feeling cold, it's body went through a lot of pressure and changes and things like that. So another thing, part of the tactile changes are that when we have these babies come out to kind of help aid in that respiratory process, we tactile stimulate them to kind of continue to stimulate that respiratory effort. In the movies, we see them flipping that baby upside down and slapping its butt and things like that. That is not necessary. All we need to do is gently tap the newborn's feet, rubbing the torso, and suctioning the mouth. And in fact, rubbing the torso is really important because we need to then dry the baby off. So I'll just take my blanket or towel as that baby's coming out of the uterus and rub it down with a blanket to dry it off. And drying it off is a huge thing for that baby too, and we'll learn that here in a few slides. And that's stimulating the respiratory rate to breathe, along with the cold and the sound and the light and chemical factors going on that are part of that gas exchange and everything. Okay, so I kind of went through some of these slides, right? That first breath forces fluid that is in the baby's lungs that are only there to keep everything open while in utero to come out. If that fluid doesn't come out, we have other issues. So they end up having some negative pressure that goes on, which is then causing chemical changes. We cut the cord. And that's also causing chemical and pressure changes in the baby's body. The alveoli start to open up, and surfactant, which doesn't start produced in the baby's body until 34 to 36 weeks, is produced even more. And that helps reduce that surface tension of the alveoli and allow that baby's lungs to stay open while they breathe. All right. This is just a visual, kind of like a concept map of everything going on in the baby's body to get that respiratory drive going. Yes, when the baby's in utero, it looks like they're breathing. They're not really breathing on their own because the placenta is doing the gas exchange and all of that. Basically, the mechanism of breathing in utero is to strengthen that diaphragm muscle so that when that baby starts breathing on its own, its muscles are strong enough to breathe on its own. Okay, not only was the lungs going through a lot of changes, the heart is still going through a lot of changes. When the baby is in utero, the heart and this blood circulatory system is actually in a mixed system. It's a mix of deoxygenated and oxygenated blood and all of that going through. It is not a split system that we are known of the deoxygenated blood and oxygenated blood. To allow for this mixing of blood, the newborn actually has 3 major shunts. The foramen ovale, let's see if I can zoom into this a little bit. Okay, the foramen ovale, which is right in here, where I have that circle. The patent ductus arteriosus is right here, or ductus arteriosus, and the ductus venosus is right here. Okay, so this ductus venosus that is circled in yellow closes off when we put the clamp on the cord. This actually is a vein that is connecting through the abdomen and down, all the way through, and it eventually connects to the umbilical cord. So when we clamp that one, that closes off and becomes the ligament trace. The foramen ovale closes off when we have oxygen pressure changes. That's right here. The foramen ovale is a hole that is open between the right and left atrium, and it just closes off, and I don't know what the terminology for it is, but it just closes and there's no longer a hole between those 2 arteries. Okay, let's see if I can, there we go. Now, the ductus arteriosus is the last one to close. These first 2 are closing pretty soon after birth, minutes to hours. This ductus arteriosus, which is up here, ends up becoming the ligament trace. The ligament trace, or the ligament arteriosus, excuse me, the ligament arteriosus closes off somewhere between 10 hours and several days of life. It takes a little bit longer, and this is when that oxygen level and pressures are starting to grow and everything like that, and then that causes that to close off. So we know we might hear murmur or have that open for a while after birth. But as soon as it closes, that is when that baby's body starts having that adult circulation that we all know. So these next few slides just kind of go through what I just explained when we were looking at that graft. So that oxygen dilates the vessels, and then more flow increases, and then the pressure increases, and then all of, vascular resistance increases and allows those shunts to close. Okay. Okay, so that just kind of explained how some of those shunts are closed on their own. Okay. I like this graft right here. It's going to be kind of hard for you to see on this slide, but hopefully you can see it a little bit better on your slides at home that you've printed off. So what I want you to concentrate on in this picture is this first line here and this line here. So what it's saying is like the umbilical vessels, what causes that change at birth is the cord is clamped. The ductus venosus is the cord closes, and then we have flow that changes. Let's see if I can do that, move it again. Not wanting to work. The ductus arteriosus is increasing the blood level, and the PDA is the pressure and the oxygen increasing. So just kind of look at the first line here, and then this fourth column here. Okay. All right. Thermoregulation is huge in our pediatric population. Actually, these babies, since if they aren't stabilized with their thermoregulation, that can actually cause a lot of stress and problems on their bodies. And me, when I'm taking care of these newborns, whether especially in the NICU, but if I get pulled to general peds or a mother baby unit, I kind of refer myself to the NICU Nazi, because I know if these kids get cold, that it can actually spiral them down into a lot of problems. So I don't allow the parents to change their clothes 5 times and undress them every time a visitor comes in, because everybody has to look at every little inch of the baby and see that, yes, it truly is a boy because it has a penis, or a girl because it doesn't, or to see each and every little toe and stuff. And I will stop people from doing those things and be like, is it time to undress this child? And if it's not, then I said you can wait till the next diaper change or whatnot. Okay. But anyways, temperature regulation is really important in these babies. As soon as they come out of utero, they lose a lot of their core temperature. And they will be down sometimes like 36.5-ish. And not 36.5, 35.8, 35.4, that kind of thing. And we don't want them to stay at that temperature very long. So we want to get them warmed up pretty quickly. So as soon as they come out of the uterus and are born, we're drying them off. We're putting them on mom's chest and wrapping everybody in clean clothes after our clean warm blankets after we've removed the dirty wet ones. And hopefully then we'll be assessing that temperature pretty quickly, and we will get them stabilized to 36.4 to 37.5 or 36.5 to 37.4 within a pretty quick period, and we'll keep them stabilized to that before we do our first baths and things like that. Some hospital protocols say that you can do the first bath as long as they've been in that stabilized temperature for an hour or two. And some nurses will do that bath at 36.5. The problem with that being is they might lose a lot of their temperature really quickly during the bath, and we might then have to work them back up to a high temperature, and that can cause problems. So this is where me, Emily, the NICU Nazi, comes in, and parents and other nurses kind of roll their eyes at me. But I don't typically do that first bath until they're even higher in that temperature range, like 37, 37.1, things like that, because that gives me a few extra degrees of temperature to play with, so hopefully they won't get as cold. Okay, so the things that are critical to the newborn survival with thermal regulation are their main heat sources: the heart, the liver, the brain, and then this small amount of brown adipose tissue. Babies don't have white fat. They don't have all of that stuff that you and I have. And so they just have these small amount of heat that they can generate. And once some of that heat is gone, then they don't have it anymore. So the brown fat is kind of seen in these central core locations. The core area of the chest, around the heart, and on the edges of the lungs, and down their abdomen around their belly button, and then above their shoulders and around their kidneys. Once this brown fat is gone, it's gone, and the baby doesn't have it anymore. So that's something to think about too. So what puts these babies at high risk for heat loss is their large body surface area in comparison to their size. Their skin is also very thin, and therefore the vascular system is also on the very outside part of their body as well, so they lose temperature faster. Okay, babies also can't shiver, and as we know, shivering increases our temperature, and so babies can't shiver when they are cold, and therefore it can't produce heat. So that puts them at high risk for thermoregulation issues as well. So there's several different things that can lead to heat loss: evaporation, conduction, convection, and radiation. So what are each of these things? Evaporation is the force of losing your temperature through water, sweat, and things coming off of your skin and drying. Conduction is the loss of heat through touching a cold surface or a cold surface touching you. So the bed, blankets, stethoscopes, hands. So you'll see me a lot as I'm walking into the patient's room. I've used my hand sanitizer and I'm rubbing it in my hands. And even as soon as the hand sanitizer has fully rubbed into my hands, I'm still rubbing them. What am I doing? I'm generating heat. And then I'll pick up the stethoscope and rub it in my hands as well, or sometimes on my scrubs a little bit to make sure it warms up before I listen to the baby's heart or their lungs. Things like that, so that I am not causing them to lose heat when I'm touching them. Convection is a loss of heat through air movement. So we don't want to have a lot of drafts. We don't want to have fans going directly on the kids, things like that. We also have radiation. Loss of heat through radiation is loss of heat by being close to a cold surface. So for instance, wintertime is one place that I think we see this a lot more, is I could be sitting in a chair that is right next to a cold wall, but not touching the cold wall. And as the wind is blowing and everything, that cold air seeps through, and then I start getting the chills. Same kind of concept when you're in the car and your arm is on the door, but it's not touching the window or not touching anything that's cold. And, as it's getting colder and colder and you're out in the car longer, sometimes that cold air seeps through. That is how kids lose heat from radiation. You guys should have a handout for the evening weekend class. I believe you should be getting that handout today from Brianne in class. That kind of talks you through 4 different beds. The only beds that is going to prevent pretty much all of these is an isolette, and it's the one that looks like a box on the back. This is also the bed that we would use when we're transporting a baby throughout the hospital and things, because it is a controlled environment. A crib and an isolette are almost identical. One is just smaller than the other, and they really don't prevent the baby from losing heat from any of these methods. Okay. So this is just a series of pictures of explaining the different ways we can lose heat through those 4 different methods. Okay. 16, 17. Okay. All right. All right. So lastly, thermoregulation. So why is it so important to make sure that we are keeping these babies warm? So we talked about that they don't have a lot of stores to keep them warm. So when they start getting cold, they go through this thing called non-shivering thermogenesis. So what happens is they're starting to get cold and everything, so their body starts using up those stores. So it starts using that brown fat. And that brown fat is very highly vascularized. It's very dark and has huge fat deposits. And it has a very large blood supply. So that then it can distribute this heat that it distributes throughout the body. It metabolizes lipids really quickly, so that baby can warm up extremely fast. However, it depletes very quickly as well as that baby continues to get cold, and leads to cold stress. Okay? So what happens when the kid is going through cold stress? Well, oxygen and energy is then diverted from the brain and heart for that child to go through thermogenesis. So the oxygen and energy goes through to the brown fat and to help the metabolizing of that so the baby gets warm. So that then increases the baby's oxygen needs on the body. So what do? They breathe harder and faster, which then leads to respiratory distress, which then makes their body work even harder. Then that brown fat's part of their stores. So then they start using up their glucose stores. And so then they start having hypoglycemia. And then they start having metabolic acidosis due to everything being broken down and their oxygen needs and everything. Okay, so these kids become hypoxic. And then surfactant starts decreasing in production, and then their lungs don't work as well. And then we have this vicious cycle that just keeps going on and on and on. And these kids end up going through some sort of respiratory distress. These kids also end up having high levels of bilirubin in their system, so they end up getting jaundice because as that brown fat is being broken down, and red blood cells are being produced because of the oxygen demand, the bilirubin isn't able to be broken down, so it continues to float around in the baby's system. Okay, so this is why we don't like to let those babies get cold, and that's why I call myself NICU Nurse Emily Nazi, that the moms and dads and grandmas and grandpas don't always like, because I don't let them undress those kids constantly and do baths too early, because I don't want these babies to get cold and sick and have to go to the NICU. Okay, so we want to maintain a neutral thermal environment. A neutral thermal environment will be a term you'll hear not only in this class but in future PEDS classes, is an environment that is going to keep that baby warm. So for a baby that's not having any problems, it could be in a crib, swaddled. For a baby that's cold, a neutral thermal environment for him or her will be getting him into a bed that can help produce heat and then prevent any heat loss. Okay. Another neutral thermal environment we might use as this kid is getting cold is skin to skin or kangaroo care. Okay. This is one of my first lines of defense when I start seeing a baby's getting cold, and this is one of the few times that I want to strip the baby down to being in a diaper just because. Because once you put that baby skin to skin with its parent and cover them up with a blanket, our bodies start working harder and start generating a lot of heat in a good way. And then that baby's going to warm up really fast. And actually it can help with your survival. So if you're ever in a situation where it is extremely cold and your temperature is dropping rapidly and you're struggling to stay warm and you know you're not going to be able to get to warmth quickly, this is why they say that two people should strip down naked and lay close together and lay all their clothes and blankets on top of each other, because your bodies being that close together generates heat that's going to help you survive. These babies don't typically go through hyperthermia, but if they do, it's usually a sign of infection, and that, or we are warming them up too fast. So this cold stress that I just went through, this is a nice concept map talking about everything I just went through, about what's going on in the body of that infant. All right, fluid and electrolyte balance. Another thing babies are highly at risk for is fluid and electrolyte balance issues. Newborn's body weight is 73% fluid, and of that fluid, the majority of it is extracellular fluid, which then puts them at a higher risk for fluid volume loss. And as we grow and get closer to adulthood, that fluid body weight compared to fluid gets less and less, but also the amount of that fluid being extracellular versus intracellular becomes less and less. So once we get in through school age and upper school age, that's when we start having less likelihood of dehydration issues. Okay. Babies have a higher fluid exchange. Metabolism's a little bit faster compared to their size. Acid forms quicker. So they go into acidosis a lot faster. Their kidneys are immature. They can't concentrate urine. Urine concentration, 1.001 to 1.010. Okay, so significantly different than the adult. Some other things going on with the infants is their GI system is immature, so it doesn't have a lot of lipase for fat absorption, which is why we don't start introducing cow's milk until they're closer to a year. Their tummies are very small. In fact, a newborn baby on the day it's born is about the size of a pea, and then day of life 1 might be the size of a grape, and then a walnut, and then it gets bigger and bigger and bigger. And that is directly in proportion to how mom's milk comes in too. Typically when mom's milk starts coming in the day of delivery, it might be only a few drops of milk, which is all the baby's body can handle. They don't have a lot of saliva. In fact, they don't typically produce saliva till they're 2 to 3 months of age. And we know saliva helps with breaking down of food and things. So another reason why we don't start introducing them to food until they're bigger is because their body can't handle it to break it down. So we don't typically introduce foods to them till they're closer to 4 months, typically closer to 6 months of age. Liver is immature. And that helps produce enzyme activity and things like that. The colon is very small. Intestine is large, but the peristalsis is super fast. And so therefore they digest their food almost as fast as they're eating it. All right, newborns poop. We have several different types of poop. Meconium is normal. That's meconium right here. These two are the milk stools. And then this is another kind of milk stool. And these three would be not normal. Meconium is that first stool that's really tarry. Hopefully they expel that within the first 24 hours. And then over the next few days, it's going to go from this black tarry stool to a brownish green color. And then eventually it starts getting to the milk stool looking. So milk stools. Oh, this is meconium. Can you see how nice and tarry and sticky it is? And it just kind of sticks everywhere. Milk stools. If you're breastfed, the stools are seedy, mustardy color, a little bit more frequent stools. They tend to be sweeter, sour, sometimes a little bit more runny. Formula smells have more of a strong odor. It's yellow, pale, and brown and firm. Breastfed babies can have anywhere from 6 to 10 poopy diapers a day. Formula-fed babies can have 1 to 10 poopy diapers a day. Typically, formula-fed babies have less stools. The iron that the baby has in his or her system at birth and what they get through breastfeeding and formula is all they need. And so they don't need supplements typically until we start introducing solid foods to these babies at closer to somewhere between 4 and 6 months of life. Carbohydrates, what they get through formula and breast milk is also all that they need. They're at high risk for glucose hypoglycemia. We want them to be 60 to 70 as a low and up to hundreds as a high. But if they're 40s, 50s, that's when we might kind of worry about hypoglycemia and we'll want to start doing restoring their sugars. So we want to feed first, whether it's breast milk or formula. If that doesn't increase their blood sugars, then we'll do glucogel in the buccal area of their teeth or their cheeks. If that doesn't work, then we admit them into the NICU, start an IV with a dextrose solution. Bilirubin. So I mentioned bilirubin levels earlier. We're going to watch these kids for high bilirubin levels and issues with that. We are going to look at their skin, their eyes, and everything. They're at high risk for hyperbilirubinemia for multiple reasons. So, what causes the bilirubin levels to go high? So the bilirubin needs to go from an unconjugated to a conjugated state. And what affects that is the red blood cells and the amount of food the baby's eating, if there's trauma, bruising, things like that. If the liver isn't able to conjugate the bilirubin to expel it through the urine and then stools, then they have this unconjugated bilirubin that floats around in the system and leads to kernicterus or nicterus. That leads to breaking down of neuronal or brain cells, and we don't want that. We typically don't worry about kids' bilirubin levels being too high to start causing issues until we reach levels of 15 or higher. Most of us should be walking around with levels of 0 to like 0.5, that kind of thing. So what causes this conjugation to not happen? Well, our red blood cells, the lifespan of them. Normal adult hemoglobin has a lifespan of around 120 days. Infant or fetal hemoglobin lives for about 90 days. So it breaks down a lot faster, and therefore we're producing it more. And so that affects it. That liver is immature, so it's not able to necessarily break it down as well and as fast as possible. If the baby's not eating well, they won't pee or poop. So that's going to affect it. And then if they get cold, and those fatty acids that are being released by the breaking down of brown fat won't allow the liver and everybody to conjugate the bilirubin, and then the jaundice levels go up and up and up. And this is just a concept map explaining all of that. So cephalehematomas, bruising, that kind of thing. When we have those things, what's happening is we have pooling of red blood cells, and we're producing more red blood cells to help with the healing, and then that just causes this process to be worse. The renal system, the urine output is poor, or not poor, but they don't concentrate urine like I was saying earlier. The newborn, to figure out if they're having enough urine output, and this even is accurate for kids older than this, is 1 to 3 milliliters per kilogram per hour. So newborn through probably adolescence will use this formula to make sure they're having enough urine output. Their bladders are super small at first, and it only holds a few milliliters, 15 to 30 milliliters. So that's why they have so many wet diapers. They should pee by the first 24 hours of life. They can have anywhere from 6 to 10 wet diapers by the time they're a week old. It slowly increases as they get past that part. The skin we've mentioned earlier is very thin. It's immature. They do have sweat glands. They do have operculin glands. They're small and non-functional. Growth phases of hair follicles is actually very slow. And it doesn't go occur as fast as when they're losing hair. So that's why we can have these babies with huge heads of hair that end up having bald spots and losing a bunch of hair, and it not growing in until they're much older. Melanin in our system is very low at birth, and so kids that would typically have high amounts of melanin at first may look very pale or Caucasian-like. However, their scrotum or their labial area tends to be a little bit darker, and so we can typically see if they are actually Caucasian or African American by looking at their melanin. The immune system is very immature. What they have of the immune system at birth is natural immunity they get from their moms through being in utero, and they keep some of those stores with them, and then through breast milk. They really don't start producing natural immunity until they're a couple months old. Okay. This is also going into some of that natural immunity. Okay. Vision. They have pearl, not perla. People are equal to reactive to light, but they do not accommodate yet. They won't learn to do that until they're a little bit older. They see about 7 to 8 inches away, so that's about from where your head is to about your chest area. The tears don't really start to produce for a couple weeks of life. Their hearing is super sensitive. In fact, they sometimes say they're better hearers than you and I, but it should be working. Smell, taste, and touch should also be able to react and perceive that at birth as well. All right, we're almost done with this one. So this period of reactivity is during that first day of life. And then once we get through this period of reactivity, these babies will go through normal sleep-awake cycles and could sleep anywhere from 18 to 20 hours or 22 hours a day. So they might be awake for 5 minutes here, 15 minutes here, and then sleep for 2 hours, and then wake up to eat for 5 minutes and go back to sleep for 2 hours, that kind of thing. Okay, so the first period of life is from birth to either 30 minutes to 2 hours after birth, and this baby's wide awake, alert, moving around, rooting around, and wanting to eat. So we'll want to try our first breastfeedings and bottle feedings at this time. After that 30 minutes to 2 hours are up, they go through this period of decreased responsiveness, or a period of sleep. This is when they're so deep asleep that any sound that would wake the dead would not wake them up. Okay, this could last for another 30 minutes to 2 hours or longer. And then we'll go through this second period of reactivity, which then occurs for another 2 to 8 hours. And they're wide awake, moving around, and all of that. Another time to do some feedings and things. And then after this period, they go through those normal sleep-awake cycles. These behavioral states, we all probably go through them: quite late, sleepy, drowsy, crying, all of that. The next few slides are pictures of all of those. Deep asleep. They would not be sleeping on their side. They would not have a pillow with them. This is light asleep. They move around. Little noises will startle them, but they're sound asleep. Drowsy. I'm either just got done being eating, so I'm ready to go to sleep, or I'm just waking up from a nice long nap. Quite alert. Just happy little baby. Active alert. This baby just got a bath and is shocked. And then crying. Oops. And then crying. Hold on, crying. Madder than a hornet. This is not a good time to try to attempt breastfeeding or bottle feeding either, because these babies are too upset that we won't have good attempts. And that's all I have for you on infant adaptations.